We are going to talk about the therapeutic uses of opioid antagonists, pain part 17.
Objectives, really short lecture today. Treatment of opioid overdose, management of constipation, management of abuse syndrome. All this is Dr. Mobeen Sayed from drbeen.com. Welcome to the last lecture in the series of pain management or opioid and opioid management, opioid use disorders with the opioid management, pain management, and DEA requirements as well. So let's start. This will be 17th lecture. Total credit hours in this series are about 12. The DEA requirement are 8. So hopefully this would be sufficient for your needs. Let's start.
Therapeutic uses of opioid antagonists.
And as you can see here, I have a couple of interesting credentials that have been endorsed to me. One is King Edward Medical University have made me a visiting faculty. And secondly, I'm now an advisory board member of the journal from King Edward Medical University. I am a student and a graduate of this college as well. Okay, so disclosures, I have no disclosures. Objectives, really short lecture today. Treatment of opioid overdose. These are the therapeutic uses of antagonists. Antagonists are the ones that are against the opioid, that are going to counter the opioid. And we've done that discussion in detail before for what the antagonists are. So treatment of opioid overdoses, management of constipation, management of abuse syndrome. So treatment of opioid overdoses. Opioid antagonists can be used for the opioid overdose. However, the drug that has become established for the opioid overdose management, especially the respiratory depression management, is Naloxone. So we'll focus on Naloxone today, and we discussed it last time as well, that there is now an over-the-counter Naloxone preparation available for nasal spray as well. So we'll talk about that too. Naloxone is an important opioid antagonist with an established use to treat opioid-induced toxicity overdose. It is particularly useful for the opioid-induced respiratory depression. Its specificity is such that the reversal of respiratory depression by naloxone is virtually diagnostic of opioid-induced toxicity. What does that mean? That means that when you give naloxone and the patient improves, that means that the patient had opioid toxicity. If the patient does not improve, naloxone does not hurt them usually. So it is safe to be administered even if you do not know if the patient has the opioid-induced toxicity. It rapidly reverses opioid-induced respiratory depression, even in high doses of opioid use. Caution is needed. So this is the only thing to keep in mind, that as you titrate the dose, if you increase the dose, it is possible that opioid withdrawal would appear. And we had this discussion in detail last time as well, that withdrawal could create withdrawal symptoms, for example, hypertension and tachycardia. So that as a provider, as a physician, you have to be careful. As an emergency responder, you have to be careful. As the duration of action is short, and we did this discussion last time, its half-life is about an hour, but clinically efficacious duration is even shorter. So as the duration of action for naloxone is short, continuous repeated infusion is given. What happens is, if a person with the opioid overdose is in the hands of emergency responders, add an infusion, and they can continue to give an infusion of naloxone. On the other hand, at home, the nasal spray or the auto injector can be repeatedly used. So 0.4 milligram of naloxone via auto injector can be administered every 2 to 3 minutes till the emergency responders arrive. Over-the-counter naloxone nasal sprays are now approved as well. And we did this part of the discussion last time, so I'm going to just quickly go through this for completion's sake of this lecture. So FDA approved the first over-the-counter naloxone nasal spray. This is March 29, 2023. FDA said that today the US Food and Drug Administration approved Narcan 4 milligram naloxone hydrochloride nasal spray for over-the-counter non-prescription use, the first naloxone product approved for use without a prescription. Then they said the approval of OTC Narcan nasal spray will require a change in the labeling for the currently approved 4 milligram generic naloxone nasal spray products that rely on Narcan as their reference listed drug product. So this is for the producers. The use of Narcan nasal spray is in individuals who are opioid dependent may result in severe opioid withdrawal characterized by body aches, diarrhea, increased heart rate, tachycardia, fever, runny nose, sneezing, goosebumps, sweating, yawning, nausea, vomiting, nervousness, restlessness, irritability, shivering, trembling, abdominal cramps, weakness, and increased blood pressure. So as you saw before, the reference before was textbook. So they only said tachycardia and hypertension. This is FDA. As part of their approval, they have listed the most probable side effects that can happen. And so one has to be aware of this. Then this is the medical news today, Narcan overdose. There is no maximum. So we're not talking about opioid overdose. We're talking about the opioid antagonist that is being given for the for management of the overdose. Can that antagonist, that is naloxone, can naloxone have an overdose? So there is no maximum recommended dose for Narcan, and you can't hurt someone by giving them more doses of Narcan than they actually need. In fact, if someone has overdosed or possibly overdosed on opioids, so see, on possibly, meaning you are not aware, you should give them Narcan every 2 to 3 minutes until they begin breathing normally again. After calling 911, you should continue to administer Narcan as needed until emergency medical staff arrives. Now, continuing, this is going to be the newer part of the discussion. Naloxone is also indicated for the neonatal respiratory depression secondary to the intramuscular or intravenous opioid administration to mother. So mother has the opioid, and from her, the opioids have gone to neonate and the newborn. And let's say the newborn is in respiratory depression. So in that case, naloxone is also used for that. So initial dose is 10 microgram per kilogram of baby's body weight, given intravenous or intramuscular or subcutaneous. So this is the new information compared to the last time. That mother had opioids, baby is born, baby is in respiratory depression because the opioids entered the baby's body as well. So in such case, naloxone is also recommended for managing this situation. Now, management of constipation. We had some discussion about this last time as well. And that is patients who are on opioids, they can develop GIT motility issues. Their gastrointestinal system can become slowed down and they can develop constipation. So in such cases, you would like to either think about it. Let's say we say we should discontinue opioids. But the problem is that normally you're giving opioid, you're already very, very careful for who gets the opioid, and you're giving opioids to someone who needs them. So now you cannot just discontinue them because they are constipated. So in such case, you are looking for an opioid antagonist that stay within the peripheral system, that stays within the body and does not go to spinal cord and brain. We discussed it last time as well. So how do we do this? What we do is we take the opioid antagonist and we modify that molecule in a way that it cannot cross the blood-brain barrier anymore. That way, this molecule would now stay within the body and counter the effects of opioid within the body that would help relieve the constipation and GIT issues. So here, GIT motility and constipation secondary to therapeutic opioid use. So secondary to therapeutic opioid use. We'll also discuss after surgery, post-surgery ileus. So in a second, patients undergoing chronic opioid therapy may experience GIT motility issues and constipation. This could be for chronic pain or methadone maintenance, the opioid usage. Generic opioid antagonists have lesser value in this situation because if you give a generic antagonist, it's going to just antagonize opioid everywhere. So what is the benefit that on one end, you are administering opioid, then you are giving the opioid antagonist to cancel them, the whole effect will be neutralized or reduced. So generic opioid antagonists have lesser value in this situation as these will counter the effect of opioid at all tissues, while the central effects of the opioid therapy is desirable and intended. So we want the central effect to be there. We want the effect of opioid on the brain and spinal cord for analgesia to be present. However, we do not want the peripheral effect, and that is on the GIT. In such cases, peripheral antagonists can be used. Examples are methyl naltrexone and naloxone or naloxegol. Then, ileus, secondary to the administration of opioid post-surgery. So somebody underwent surgery. After the surgery, they are given opioids, and now they have developed GIT motility issues. This ileus needs to be corrected as well. So how do you do that? Once again, you need peripheral antagonists. So another use of peripherally restricted opioid antagonists is to manage ileus. This condition is called ileus. Ileus or reduced GIT motility secondary to the surgery and opioid administration can occur. Ileus can happen. Peripherally restricted opioid antagonists will help manage ileus without impacting the central analgesic effect of opioids. So I hope this makes sense now. We have repeated it. We discussed this last time as well. We repeated a couple of times here as well. We have modified antagonists that stays within the peripheral area and help GIT. Now, there is another important thing to keep in mind, that there can be ileus management with alvimopan. However, this is important to know more about it because it has a black box warning. FDA has approved alvimopan for the management or to manage post-operative ileus. So ileus after the surgery when the patient is given opioids. In patients with less than 7 days of exposure to opioids immediately prior to beginning alvimopan. This you could see would become a CME question as well. So what we are saying here is that a patient can only receive alvimopan if the patient had post-operative ileus and the exposure to opioid was lesser than 7 days. So imagine if I got surgery today and they put me on opioid today, and then you start alvimopan tomorrow, that is fine. So you can start that within 7 days, not after that. Dosage, the usual dose is 12 milligram taken just before surgery. So imagine if again, my example, I have a surgery today. So then just before the surgery, 12 milligram of alvimopan is given, followed by 12 milligram twice a day for a total of 7 days. This medication has a black box warning because prolonged use can increase the risk of heart attacks. This is why it is not given for long duration. Therefore, it is only available for short-term use up to 15 doses. So as you can see that the first dose is before the surgery, then you're left with 14 doses, which are 2 doses daily. That means at most 7 days after the surgery. Alvimopan is a mu opioid receptor antagonist with a quaternary amino group that restricts it to the periphery. So this molecule has a amino group attached to it, which would not let it cross the blood-brain barrier. A deamidated metabolite of alvimopan slowly appears in circulation. So what happens is, if you forget about the text for a second, imagine that patient is given alvimopan. The GIT, when they have taken the drug, in the lower GIT, we have microbiome, right? But those bacteria present. These bacteria are going to act on this drug and they would deamidate it. They would take the amide group, one part of the chemical molecule, and remove it. So now we have two molecules in the gut. One is the alvimopan itself, and some of the alvimopan has become deamidated by the microbiome. Both of these molecules, the parent molecule and some of the converted molecule, they both have a half-life of 10 to 18 hours. They both start appearing in the circulation and they would act on the GIT for the GIT issues. Then what happens is, this is even more interesting, the alvimopan would then go to liver, because when we have something in the GIT, those molecules or nutritional substances, for example, they will be picked up by the gastrointestinal circulation and bring all that blood with those nutrients, with the drugs that we have taken, to liver. Now, liver can, number one, modify them. Number two, there can become a hepatoenteric circulation where the liver would secrete it back in the GIT through bile. So now the drug is going back in the GIT, then getting modified by the microbiome. The parent drug would then get absorbed and go back to liver, then from liver go back to GIT, and this enteric circulation would start. So drug would continue to circulate in this process and keep microbiome, like those little laborers, would continue to work on the drug to break it down, or not break it down, deamidate it, and that would be the two drugs that would act on the GIT for the paralytic ileus or post-surgical ileus. Very interesting drug. So alvimopan is a more antagonist with a quaternary amino group that restricts it to the periphery. A deamidated metabolite of alvimopan slowly appears in the circulation after the administration of alvimopan. This metabolite is attributed to microbiome working on it. This metabolite is also mu opioid receptor antagonist. This would be another CME question, for example. Alvimopan seems to become part of enterohepatic circulation. Both the drugs and its metabolite have a half-life of 10 to 18 hours. Both the drug and its deaminated metabolites are excreted in urine and feces. So some of it will get out through fecal route, and some of this would get out through the urinary route because it is appearing in the circulation as well. So now for paralytic, or for post-surgical ileus, you are seeing that these are some of the possibilities. And the final topic for today, as I said, today will be fast, management of opioid abuse syndromes. So naltrexone is approved by the FDA for treating alcohol dependencies. So not just opioid, but other than opioid abuse syndromes, for example, alcohol, treating alcohol dependencies, blocking the effects of externally administered opioids, preventing relapse into opioid dependence after detoxification. So if somebody said, what are the important actions of naltrexone? And we are not talking about low-dose naltrexone. That's a different thing. We have done a separate lectures about that. This is naltrexone. So 3 actions. Number 1, treating opioid intoxication. Number 2, alcohol dependence. And number 3, if somebody has become detoxified from opioid use, now you want to prevent them, protect them from developing opioid use disorders again, then you continue them on naltrexone so that even if they take opioids, these opioids cannot work on the opioid receptors because naltrexone is covering those receptors, so patient is protected. Naltrexone in combination with Bupropion is also FDA approved as an adjunct for weight management in patients with obesity. And you probably remember that we had this discussion last time. Individually, these drugs, they do modulate hunger, but they do not work as a weight loss drug. However, naltrexone with bupropion can be combined, and it is FDA approved for weight loss. There has been interest in using opioid antagonists like naltrexone and nalmefene, not available in the US, as adjuncts in the treating various non-opioid dependent syndromes such as alcoholism. These antagonists may reduce the relapse rate. Notably, patients with a single nucleotide polymorphism in the mu opioid. So some people, not everyone, some patients have their mu opioid receptor with a single nucleotide polymorphism. So that is a gene that makes that receptor has a tiny change in it, one nucleotide change. Such patients have significantly lower relapse rates for alcoholism when treated with naltrexone. So not for everyone, but some people, they make their mu opioid receptor and their, let me actually draw this. Give me 1 second. This is the last point anyways. So what happens is, imagine that this is the nucleus, here is DNA, and imagine that this is the DNA that would be the gene for mu opioid receptor. So what will happen is the mRNA will be formed from here as the gene will open up. The mRNA would form, that would come out, it would go and work with the ribosome, and the ribosome will then make the protein that will then become folded into mu receptor. Remember, these are serpentine G proteins. Some people have one nucleotide change, meaning one nucleotide that is different from the rest of us, that gives their receptor some slight difference. Such folks, if you give them these drugs, for example, naloxone, they have a better tendency to then resist alcohol dependence or alcohol dependence relapse. So let's read the exact statement. Notably, patients with a single nucleotide polymorphism in the MOR gene have significantly lower relapse rates for alcoholism when treated with naltrexone. So these are the references. And with this, thank you very much. This is the discussion.